I'm going to go through this in a very short history lesson, which is how is our thinking about MIS surgery for scoliosis changed? And there have been 3 inflection points that have occurred since 2016. And then the question is there a 4th inflection point that is soon on the horizon? And those inflection points illustrate a lot of the concepts. So these are my disclosures. We all know what the goal here is. We're trying to reduce pain generators. We are trying to maintain or restore spinal balance. And we're trying to create an arthrodesis for durability in the properly selected patients. And our understanding of these concepts of spinal parameters has evolved dramatically over the last decade. Virginie Lafage and Frank Schwab and the ISSG group have really done a mountain of work helping to correlate the relationship between spinal parameters and logic and the implications for decision-making in spine. And we talk about in these courses and in labs and at national meetings, we spend so much time talking about the big stuff. We saw Dr. Pham and his plethora of technology in the room trying to achieve something. But I think it's also to remember that the single most common thing that I do in my scoliosis practice is nothing. That's the most common treatment plan, is a non-surgical treatment plan for a patient who's referred to me with scoliosis. So we have to remember that we're talking about an end game of a shrinking pile of patients. That's the most common thing that I do for a patient who's referred to me with scoliosis. The second most common thing that I do is I deal with their radiculopathy, which is often L3 from the ill-listhesis at L3-4. And I can achieve that many times with a foraminotomy, but sometimes I need to do, and I'll often do an MIS TLIF in that situation, actually, because if I'm concerned about the ill-listhesis and the collapse at the apex on the concavity, which is where the pain is, that if I just do a decompression, it just collapses further and the radiculopathy recurs or never actually resolves. So I will very commonly do a single-level MIS TLIF for a scoliosis patient who's got a wicked curve, but that's not their problem. They've had that curve since they were 14 years old. Their problem is the L3 radiculopathy or the L5 radiculopathy and the fractional curve. So I didn't put it up here, but a single level ALIF is also a very common thing for me in a patient with a wicked deformity. And then comes open posterior spinal reconstruction, which happens way more frequently in my life than hybrid surgery, where part of it is done MIS and part of it is done open. And one of the main reasons why I have to do open posterior corrections is that I'm not the first person to make an incision on this person's back. And so the person who has had an L3 to 5 fusion or an L2 to 5 fusion, I haven't yet figured out how to correct the rest of that person's deformity minimally invasively against that 2-3 level fusion. And that's a pretty significant percentage of the patients, the adult deformity patients who need surgery. Then comes hybrid surgery, and this is in decreasing order of frequency, where part of it's done MIS and part of it's done open, and then there's this very special group of patients who get what we call in the ISSG the CMIS patients, the circumferential MIS corrections, which are done through an all MIS approach. So we have had a significant change since 2016, and this has been the professional walk with Adam Cantor, who I've just been extremely fortunate that he and I have worked together for 20 plus years now, and we've done this together. And it's been really wonderful, but we stand on the shoulders of giants. And Larry Lanke taught us that the open posterior approach is exceptionally predictable and exceptionally effective. There is morbidity associated with this. You can get people through the morbidity of these procedures. They need to go into this eyes wide open about what the magnitude of that morbidity is. But it's exceptionally predictable, and it's exceptionally effective. And it still represents the mainstay of my practice. I mean, I'm sure it's the mainstay of your practice still.
Actually, it's not. And I would ask you, do you really think it's predictable for anybody but lanky? That you see, right? A lot of people do T10 to iliacs, and you wonder what the thought process was.
Well, that's different. Yeah, okay. So yes, it's predictable if you understand the fundamentals that go into the decision-making process that arrives at a conclusion. What's interesting to me is how infrequently I do T10 of the pelvis now.
I do it once a month.
Yeah, it's very, very rare that I do T10 of the pelvis. I'm either doing something smaller or something bigger. But it's become clear to me over time that T10, or whether that's T9, T11, that little range of the lower thoracic spine, it's actually a very rare correct stopping point as we understand more about thoracic compensation. And
it's more of a rest stop, right? Take a break and come back in 6 months.
Oh, goodness. The illustration here that I give for lanky, though, is not T10 of the pelvis, Kai, in full disclosure. But then, came Luis Pimenta, when, you guys were just ridiculously blessed to have him here with us for this course. And he started pushing the envelope in very meaningful ways. Other people like Akbarnia started to recognize the brilliance that was coming out of this concept. There's been a long history of anterior surgery for scoliosis. I mean, people have been doing anterior approaches. Jürgen Harms, doing anterior approaches for scoliosis for decades with huge effectiveness, especially in the adolescent population. But in the adult population, it's probably not the most effective strategy. And I used to call those the shark bite incisions until Steve Monteith gave me endless grief about that terminology, so I've kind of stopped saying that, whatever. But these big morbid open approaches for thoracolumbar anterior approaches in adults, it's not trivial. So when you have a much more effective way of addressing the anterior column through a minimally invasive approach, that was a game changer for all of spine. It was a specific game changer for MIS approaches to scoliosis. And then when that got taken to the next level with resection or transection of the anterior longitudinal ligament and anterior column realignment with hyperlordotic cages, that was the first critical inflection point that allowed us to start tackling more complex deformities with minimally invasive approaches. And the principal advantage of the anterior column realignment of the ACR over a pedicle subtraction osteotomy is that the blood loss is literally a fraction. And Reg Hade was another person who had a significant influence on my thinking about where anterior column realignment fits into the world of scoliosis. And then Juan, in his infinite mania, has driven us towards data to document the value of these things. And this famous graph of his, for us who do this for a living, that the blood loss difference between a pedicle subtraction osteotomy and an anterior column realignment is just massive. For us, this dramatically expanded the indications for scoliosis. So this was our first inflection point in minimally invasive scoliosis surgery for us, was the anterior column realignment. And the idea being, this should be better in properly selected patients than the classic open posterior approach. For me, I am also perfectly content to bring as much technology into the operating room as I think is going to make my performance more predictable and safer, and ultimately better for the patient. So I am a heavy consumer of technology, and I'll give you some examples of that. So here's an example of a 59-year-old with severe back pain. You can see that her spinal parameters are out of whack. With this degree of sagittal imbalance, is this a case that can be done MIS? Well, prior to 2016, the answer was no. But with anterior column realignment, this is something that we can achieve. So we can do an ACR at L3-4, we can do laterals above and below that, do an L5-S1 ALIF, and then come back a few days later and do T11 to the pelvis percutaneously. And you can see just after the first stage, which is a little bit hard to see here because this is in the peak cage era, which I'll get to. But you can see that just after the first stage, there's been a huge change in this person. So we did part 1 on Tuesday, part 2 comes on Friday, and we get a long cassette x-ray in between, and you can see the huge difference in the sagittal balance, but also in the coronal cob between just from doing the first stage of surgery. So then we come back a few days later, and I'll do percutaneous.
Okay, I'm recording now.
I don't know why that's got such a big volume, but anyway. Go on. Like I said, I'm a heavy consumer of technology. I have the fortune of having a CT scanner in the operating room, so I don't have to deal with whatever 3D C-arm you're dealing with. When I do open cases, I can do T2 to the pelvis in a single spin and a single registration. But I can then position the patient on the table, put my navigation, so I will often use the spine mask, so I don't have to deal with arrays, I don't have to deal with putting something into the pelvis. I do a spin, I get T10 to the pelvis in a single spin, I hook it into the navigation, and then I can achieve T11 to pelvis percutaneous instrumentation with 0 radiation exposure to me or the staff. Because once we all step out of the room for the CT scan, we come back into the room for the instrumentation. I don't wear lead, which I absolutely hate. So I don't wear lead. It's a fabulous thing in my life. I don't wear lead. And I don't have any radiation exposure, nor does anybody around me. The patient gets a CAT scan, and often 2, because we'll spin again at the end. But this is a 128 slice helical CT scanner. It's the same GE Lightspeed scanner that's down in radiology. And if you look at the dose report of radiation from a 128 slice helical CT scanner, it's infinitesimally small. So it's actually not a big deal to get a CAT scan in these patients. And then I'll use the things that where I can dial in exactly what I want the rod to look like at the end. And so I can tell the rod, right now the curve has been reduced to 24 degrees after stage 1, but I want it to be 90% corrected. I just tell the system that that's what I want, and I dial that into the rod and achieve the correction that I'm looking for. And so that's what this looks like when all is said and done, and the total blood loss in this situation is 150 cc's. So that's a good thing. And that was our first inflection point, was the anterior column realignment piece. The second inflection point was the introduction of advanced material sciences into our practice. And this is the difference between success and failure. And for the folks that have been with me in clinic, I can look at an x-ray and I can tell you what year I did the surgery, because I just know how my practice has evolved over time, and I can tell that, I mean, this is very clearly circa 2010, 2011, because it's direct iliac screws with a cross connector into a parent rod. Then there are these actual cross links, which I can't remember the last time I put a cross link into a human being. And then there's peak cages. So I know that this is circa 2010, 2011, and this lady broke, and there's only 2 rods. So this lady breaks both of her rods, and it just highlights that the materials that we use matter. And the materials we use and the constructs we create have a direct effect on the durability of the constructs that are produced. So in 2019 came the second inflection point, which is this modern generation of spinal implants that are 3D printed porous titanium. These things are absolutely fantastic because they take on biologic properties. So these are fabricated metal implants that induce biologic behavior. They induce biologic behavior at the macro and the micro scale, so you get rapid osseous integration, and at the micro scale, they induce cellular ingrowth, so they actually attract cellular migration into themselves. No one can market these things as having nano properties. Nano properties would be influencing behavior at the protein level. There is reason to believe that these implants do impact the nanoscale, but no one has actually proven that. But they definitely impact the macro and the micro scale. And they also do that by also mimicking the modulus of elasticity of where they're going. So a molecule of titanium or a pound of titanium, the modulus is the modulus is the modulus. The modulus of titanium is not the modulus of cancellous or corticocancellous bone. But when you 3D print these with a specific architecture, you create a stiffness that converts it into behaving as if it has the modulus of cancellous and corticocancellous bone. And so that's the next valuable piece of these things, is that their structure mimics where they're going. And I can't actually recall a single instance of subsidence for one of our. Have you had a titanium cage, Juan? Have you had a 3D printed titanium cage subside yet?
I have it, but it seems like it's less than the peak.
Yeah, we're waiting to bring data to that fact, but I am observationally convinced that my subsidence rate is meaningfully less than in the previous peak era. Yeah. And then the last thing is that these things actually take on biologic behavior, so they actually attract cellular migration into themselves to promote the arthrodesis. In 2008, when we started this, and I was telling Adam Cantor that, dude, we can pull this off. We don't even need to put screws in. We can pull this off. We can do this through pure MIS, and that's all these patients are going to need. But we consented all of these patients with an understanding that we don't know if this is going to last. We don't know if we're going to have to do a second surgery. You know, I call this is one of what I view as one of the privileges of neurosurgery, which is when you actually have the trust and confidence of your patients to participate in these pathways with you. You know, what Dr. Pham was showing earlier, I mean, he better be engaging the trust of his patients into that process, because he's doing something that is outside of central casting. And we were doing something outside of central casting in 2008, and we weren't sure if we were right. And it turns out that we were wrong. And we were wrong because the technology had not caught up with our vision, and doing this with peak cages is just an impoverished concept. So we were having failure rates, and then the patients would end up getting the second surgery. So we stopped doing standalone lateral and anterior surgery for scoliosis after a few years. But when we got our hands on these 3D printed porous titanium implants in 2019, I started saying, okay, it's 2008 all over again, man. Here we go. We're going to start doing this again. And so here's a patient, 62 years old, severe debilitating back pain, a postural disturbance. These are her spinal pelvic parameters. Can we do this with anterior MIS surgery only? And yes, I am now confident and comfortable doing that because I have an implant whose osseous integration is going to occur fast enough and whose subsidence rate is going to be low enough that I can achieve durability for the correct select group of patients for this. And so that's now again, it's an ever decreasing size of the practice. But this is now something that's happening about every other month, where a patient is getting only anterior and lateral surgery in the setting of a deformity. We can't obviously do this to people with wicked deformities, but there's a sweet spot of the patient for whom this is appropriate. And because of the biologic behavior of these implants, we're seeing durability. And then the third inflection point came this year with the introduction of single position surgery. We've talked about this a lot, so I'm not going to belabor this. But one of the things that we are taking one step further, which was hinted at earlier, is that, you know, this is an opportunity to do osteotomies at the same time that you're resecting or transecting the ALL, so that we can get much larger implants in and then clamp down across that osteotomy, so that, you know, this is a picture with Adam sitting on a stool doing prone trans-psoas while I'm sitting up top doing an osteotomy and getting things ready for the level that we want to do the anterior column realignment. I'm doing a grade 2 osteotomy while he's coming in laterally, taking the ALL, and then we can get the right size cage and the right amount of compression in back to induce segmental lordosis. And again, with a fraction of the blood loss of a pedicle subtraction osteotomy. Now, we can't do that if that disc space is already fused, or if there's too much of a fusion from prior surgery, or the patient's already had L2 to L5. So this isn't for everybody, but for the carefully selected patient, this is fantastic. And then in that situation, that's all happening in one day. That's not staged surgery because we're doing it simultaneously. And then comes the question, is the fourth inflection point robotic-assisted, which really is more technology-assisted spinal instrumentation? You know, the Da Vinci is a robot in many ways. What we have in spine, none of them are actual robots. The day is coming where these will be robots. Where robotics has entered into my practice is this collaboration that I have with a couple of thoracic surgeons at UPMC, where for some reason we see a half dozen of these a year, of these large intrathoracic schwannomas. And so we work together, and these guys will resect thoracic schwannomas with the Da Vinci. And so it's a double lumen endotracheal tube. There's the surgeon in the field who is pulling the instruments in and out, and then there are two surgeons sitting at consoles to run the Da Vinci, and then we can then collapse the lung. And with the Da Vinci, through a couple of the stab incisions, we can get to the point where we can circumferentially isolate the schwannoma, take the nerve, and then resect the tumor and take the tumor out. So why is this possible? This is possible because the lung is a potential space. It's a cavity. We don't have cavities to go navigating through in the spine or inside of the cranium. So we are challenged if our goal is to do these kinds of things. But when this grows into the thoracic cavity, it opens the door to applying this kind of technology. As this gets applied to the world of spine and spinal deformity, you saw one example of that this morning. Juan's gone after this. He's not alone. I still view this as it stands today as simply the world's slowest K-wire introducer. And I don't see the value of this to me today in its current manifestation. So when we get another generation or two better, that's when the fourth inflection point will come to our practice. For the moment, I'm perfectly content to let the Martin Phams and the others of the world be that early adopter of the innovation to get tortured, absolutely tortured, as they work to reveal what the weaknesses are so that we can get better, and then the rest of us will benefit from that painful process that those guys are living through right now. Any questions? Yes.
That's perfect correction, but my question is, would you be able to still manipulate the body the way you want it? I saw you did it.
Yeah.
Customized patient, but how about without having osteotomies or prostatectomies, and how is it easy to manipulate?
Again, remember that this is decreasing order of frequency in my practice. So the patients where I am doing circumferential minimally invasive scoliosis surgery are not people who are already fused, are people who have multi-level vacuum discs in the lumbar spine that I see on that CT scan or the myelogram, where I'm seeing that and just going, thank you, this is heaven, because I know that that spine is going to be manipulated far more easily than the patient who has bridging osteophytes or where the disc space is already fused across. So there are a lot of factors that go into play because I'm challenged at the end to manipulate through the percutaneous screws. There is an opportunity to manipulate to some degree, and all of the systems have some sort of apparatus that you bring down over top of the screws that are meant to help you derotate and align. None of them work particularly well in my humble opinion. And so what I know is that if I haven't achieved X percent, some meaningful large percentage of what the goal is before we get to the point of rod insertion, then there's only so much I can do at that point. And so that's where the decision tree is happening in clinic. Or as I like to point out to the folks in Pittsburgh all the time, the first critical portion of the procedure is in clinic. No amount of technical brilliance in the operating room will overcome the decision-making that occurred in clinic. Yeah, Luis.
Can you tell me, when you say that the CMIS cases, you reduce the amount of levels with good results, right? Is what I understand. In my opinion, there is a big difference in adult deformity if the adult deformity is purely degenerative scoliosis or is an adult deformity from
idiopathic,
idiopathic, right? Or wrong?
Yeah, and so we're agreed. There's a difference between adult degenerative scoliosis and degenerative changes on top of an adult idiopathic curve. And by definition, all of them have a thoracic curve, even if you take them back to age 15 and that thoracic curve was non-structural in the Lanke classification, there is still some element of a thoracic curve in all of those adult idiopathic patients that now have a degenerative condition. So the thoracic curve rarely is the pain generator in the patient who has adult idiopathic scoliosis that now has degenerative change and now has a pain syndrome. The pain syndrome is virtually always a lumbar pain syndrome. And to the best of my ability, I have those people track down as much data as they can provide me, and I want to see that x-ray from 12 years ago that shows their thoracic curve is exactly the same as it is now. And then clinically, they're not having thoracic pain. When I apply MIS interventions to the adult idiopathic population as opposed to the pure adult degenerative population, it is exclusively in the people whose thoracic curves don't require treatment. And then it also has to be balanced against how much thoracic kyphosis do they have, what is the extent of degeneration such that if I just address their lumbar curve, am I either going to put them into a coronal imbalance that is going to just substitute one problem for another, or place them at risk for PJK because I haven't factored in what their thoracic compensatory or non-compensatory kyphosis is doing. So it has to be, again, clinic and the many, many clinic visits that occur before I make a decision in these patients is what drives my thinking to when that is an appropriate intervention. And it continues to be why that is the least frequent scoliosis case that I do, in spite of the fact that it is by far the thing that I've published most about in the world of scoliosis, right? There's a disconnect between the number of publications and the number of patients. The minimally invasive component of the ISSG, which has just been a phenomenal experience, with Juan and Paul Park and Praveen Mumanini and Greg Mundis and Bobby Slack and all our friends, and then we take advantage of the Kai Mings of the world from the rest of the ISSG to lend their statistical expertise and their insights into hypothesis construction and all of those things. We've produced a gorgeous body of evidence. But ultimately, what our body of evidence about minimally invasive approaches for scoliosis says, ultimately, is that if you pick the correct patient and you apply these techniques, you achieve equivalent results as the open cases. If we start applying these techniques willy-nilly, we will discover that minimally invasive approaches are actually severely inferior to open approaches if you blanket them across the world of adult deformity. Other questions?
Would it be easier to correct sagittal versus coronal IS?
No.
So coronal would be more difficult to do IS, is that correct?
It is easier to address coronal plane deformities than global sagittal plane deformities. However, in the correct patient, you can address, and I showed you examples of addressing a sagittal plane deformity through a purely MIS approach. But what I didn't get into is, again, the hours and hours and hours that I spend over numerous clinic visits to arrive at these decisions, and it involves supine and standing long cassettes. It involves physically examining the patients. It involves laying them flat on the bed and taking a step back and looking at what their posture is like. It involves asking patients, how many pillows do you sleep with at night? And if a patient tells me that they need 4 pillows to sleep at night, I already know that I'm not doing an MIS intervention on that patient. I can't give that person back a life with 1 pillow through a minimally invasive strategy, and if I try, I will not achieve the goals of surgery, and I'm very likely to leave that person with a persistent disability that requires a more complex revision procedure as opposed to just getting it right the first time. There's a lot that goes, we spend so much time talking about the technical execution, and then we all want to get into the lab and we want to get our hands wet in the cadavers in a wet lab environment to practice and hone our skills in the operating room. And there is no amount of technical performance in the operating room that will overcome the decision-making that occurs in clinic. Never. So you have to hone the craft of the medical decision-making part. And in residency programs, clinic is de-emphasized. It's viewed as torture. I viewed it as torture until I was in my last year of training and I realized, oh my God, I got to make this decision next year. And I realized I'm going to try to spend as much time in clinic with Chris Shaffrey as I possibly can, because we show up in the OR and the only goal of that day is to finish as fast as you can and get the person off the table. And when you start pestering questions about why in that situation, it's a distraction. And it's actually not helpful to the patient on the table. Those questions are better asked in clinic than they are in the operating room. Clinic is torture, but your practices will be driven by the quality of your clinic, by the process and the decision-making that you engage in clinic will dictate the success of your practice far greater than technical performance in the operating room. You can then screw up a perfectly crafted plan in the operating room. So it's important to get into the lab and practice. It's important to learn how other people do things so that you can then start to hone what it is that you do as you draw from different mentors and different people in the world, and you realize, oh, that's pretty cool. I'm going to do that. I do that myself. To this day, it's like COVID. The most painful thing of COVID for me was not being in environments like this where I soak it up when I'm hearing my colleagues speak. And I'm soaking it up when I get to go into the lab and then walk to the next cadaver and listen to someone who is exceptionally good at what they do, hear what they're saying. We're always in a perpetual state of getting better. But you have to also practice the practice of medicine in clinic. You will be better than that you'll be better with that 5 years from now than you are today. I am way better today than I was 5 years ago.
I have to say this last comment is the best thing you did, maybe the best thing in the day. We are in a world of technology, and there's so much technology involved that I am afraid that younger surgeons, they will, in the near future, just look to X-ray, CTs, MRI, because they have robotics, they have navigation, they don't talk to the patient. So it's so much more important to learn how and what to talk, what to hear, spend time with the patient. It's more important than the surgery itself.
Yeah, thank you. All right, on that note, we call it a wrap.